that anemia is a quite common childhood entity, and my discussion will be predominantly, the crux of the discussion will be the the clinical case-based discussion. I'll be giving basically different prototypes of the childhood anemia cases. Indeed, a lecture class is insufficient to cover the whole gamut of the cases, but indeed some classical prototypical cases we'll be discussing, so that you get a message about how to evaluate clinically, followed by from the laboratory evaluation point of view in a child with anemia. And at foremost, I would like to thank Sir to give me the opportunity to get involved in this academics of ICH. So I think this light off, the screen is not getting very prominent. One of the light is can might be off. It's much better. Thank you. So I will cover in the following headings. Like first, I will define anemia, the epidemiology of childhood anemia, and the epidemiology of childhood anemia, both globally as well as what is the situation in the country as well as in the state. The pathophysiology, the basic understanding. To understand the clinical scenario, you have to have a basic understanding of the pathophysiology, though we will not dwell much on this. And then the core discussion will be on the clinical scenario, and then a synopsis on the diagnostic algorithm. First, if we define anemia, as we all know, that anemia is defined as a reduction in the hemoglobin concentration or the erythrocyte volume below the normal reference range. Now, there is a pinch of salt when we talk about normal reference range. As compared to adult population in pediatrics, there is a wide range of different hematological parameters being available. And apart from age, the gender, the ethnicity, as well as the altitude of living should also be taken into consideration when we define the so-called normal range for any biological parameters for that purpose. But particularly when it comes to hemoglobin, it's widely variable based on several host-specific as well as the ethnical as well as the environmental aspects, which should definitely be taken into consideration before we define the normal range so-called. So the World Health Organization has given cutoffs to define anemia, hemoglobin cutoffs to define anemia. So in the young children between 6 to 59 months of age, there is under 5 children, they have defined anemia, any value which is less than 11 gram per deciliter. And in older children, the hemoglobin cutoff to define anemia is 11.5 gram per deciliter, and for the adolescent age, it is 12 gram per deciliter. But again, you have to understand what I just reiterated. I want to re-emphasize that these values of hemoglobin should always taken with a pinch of salt, taking into consideration the ethnicity and the altitude of living always. That means the average hemoglobin, which would be at the sea level, you cannot expect the same from a child who is coming from, let's say, a Tibetan belt, right? So that always have to be kept in consideration. So just to again reiterate the fact, recently last year in the Journal of Lancet Global Health, from India, we have now a robust data on what is the normative data of the hemoglobin trend in the Indian children. And they have tried to compare whether that matches with the standard that is being defined by the WHO. So what we have found is that this is red colored curve is for the Indian normative data as compared to this blue colored curve, which is the age specific WHO definitions of normalcy of hemoglobin. So as is quite evident from this curve that Indian children on an average has a hemoglobin trend which is below the standards which have been proposed by WHO. So but it just reiterates that every nation probably should have their own normative data rather than just believing blindly on the WHO standards. So what we have found in this particular paper on a large-scale population study is that the age-matched hemoglobin values in Indian population is lower as compared to the WHO standards by at least 1 to 2 grams. And this difference between the WHO standard and the Indian population is little more, particularly for the young children as well as for the adolescent girls. So on an average, hemoglobin range for the Indian children is on an average lower as compared to what WHO standard defines. So if we see the epidemiology, it's pretty alarming and it's pretty much painful to see for the pediatricians that the global prevalence of the childhood anemia is close to 40%, which is equivalent to a humongous figure of around 270 million children across the globe. And the prevalence in under 5 children is highest in the African countries, but nothing to be much proud about. India, because this triangular country in which we live has an equal prevalence as compared to Africa. So you can see this Southeast Asian nations and Africa, they are doing the worst as far as the anemia prevalence in the children and the adolescents are concerned. So we are really living in a nation where the prevalence of childhood anemia is really alarming, and we should work on it. If we see the statistics in the country and in the state also, so the National Family Health Survey, NFHS, gives data. So the recent data which was published in NFHS 5, that was spanning over 2019 to 21, we can see the in the young children, the prevalence of anemia is close to 70%. And the most alarming thing is that it has increased from 58.6% as compared to NFHS 4 data. So you can see the value was around 70% in the year 2005-6. And after around 14-15 years, we are back to ground zero, where we're again having a frequency of childhood anemia in the range of around 70%. If we see the statistics in West Bengal, again, just reflecting the very similar kind of data in the NFHS 5, the prevalence is around 70%, which has sharply risen from a frequency of 54%, which was presented in the NFHS 4. So there is really something which is bothersome, that the childhood anemia prevalence is increasing, both in the country as well as in the state of West Bengal. So now, if we focus on the fact that what are the keys to reach the etiological diagnosis of anemia, so one has to understand that anemia is not a disease per se, rather it is a manifestation of maybe varying forms of systemic disease that can be either a primary hematological disease or maybe any other systemic disease for that matter. So anemia is not a disease, but it should always instigate the managing physician to explore and dig out what could be the reason behind that. So the approach to a childhood anemia obviously is initially based on the two big pillars. One is a thorough clinical assessment, which is again based on detailed history, in which not only history of present illness, but also birth history, family history, developmental history should be taken into consideration. By saying family history, I mean family history of the similar diseases, history of blood transfusion. As far as birth history is concerned, often the history of prolonged or severe neonatal jaundice in the family, again any history of hydropic birth previously or any intrauterine transfusion requirement, are some of the pertinent family history that may be often important on a case-to-case basis. Thorough physical examination, not only of examining liver, spleen, and jaundice, which we think in the classical in the context of hematology, but a thorough head-to-toe examination may be very beneficial. And organs like eye, genitalia also sometimes can give you very valuable diagnostic clue to reach the diagnosis eventually. With this thorough clinical assessment, there should always be supplemented with a complete blood count with peripheral blood film, which is kind of an extended forms of clinics, we should say, in the context of hematology. So what we often, forget to look into when we interpret a complete blood count is reticulocyte percentage, very neglected but very useful laboratory entity, and detailed evaluation of the red cell morphology by examination of the peripheral smear by an experienced pathologist are often overlooked but very important diagnostic clue. Based on this clinical assessment and the complete blood film, whatever information we gather, based on analysis of those information, we can derive a syndromic or the pattern recognition. It is one of the most crux, I should say, when we evaluate a child with anemia. So the syndrome of the pattern recognition helps you greatly to narrow down your differential diagnosis as far as the etiology of anemia is concerned. And subsequently, based on that, you can tailor a subsequent investigation. If we don't follow this algorithm, which has been often been seen, unfortunately, then the evaluation of the anemia goes very erratic. That often a complete blood count is directly followed by jumping or embarking into performing an iron study, or maybe the bone marrow examination, or even next generation sequencing in the modern fancy day of medicine, which is not the way always. You should be following a very scientific, rational way of evaluating childhood anemia, like any other childhood disease for that matter. A very basic understanding of the pathophysiology, now, it cannot be overemphasized, and I think all the residents already will be knowing that the anemia could either be because of a pathology involving decreased production, or a process of accelerated destruction, or ongoing blood loss. So decreased production could be either because of shortfall of the raw materials which are required for hematopoiesis, like already know, iron and the different vitamins. It could be some very intrinsic problem of the marrow per se, like for example, aplastic anemia, or it could be a normal marrow, but let's say marrow is being infiltrated by terrorists, like something like a malignant infiltration. In that condition also, the marrow being, despite being normal, it will not function normally because of malignant infiltration. Accelerated destruction could either be because of a problem which is inside RBC, or it could be because of something which is extracorpuscular, something like an immune process. So again, a very basic understanding of red cell indices are important when we evaluate children with anemia. So the parameter that should we all remember are the mean corpuscular volume or mean cell volume, which indicates the red cell size. Mean corpuscular hemoglobin, as the name suggests, it indicates the hemoglobin content per erythrocyte. The mean corpuscular hemoglobin concentration, which basically indicates what is the hydration status. A high MCSC just indicates that the cell is dehydrated, versus a low MCSC indicates the cell is overhydrated. RDW, which is red cell distribution width, which indicate that how variability is there in the red cell size, not of the shape, of the size. That's how variable is the red cell size. So that is called red cell distribution width. And retic percentage. So retic percentage is basically none but a representative factor, or is a surrogate marker of how hard and fast the marrow is trying to compensate for anemia. Whenever there is anemia, the marrow by nature should be able to try to compensate. So how well is it compensating? Is that is being reflected by the reticulocyte percentage. So all these parameters have some standard norms, but again, these norms are sometimes variable in the childhood years. And particularly in the young children, one should always refer to the standard nomograms and not rely on these blind parameters, which are often extrapolation from the adult data. For the pediatrics, nomograms are available, and one should refer to them. So with this basic understanding of the pathophysiology and the basic key tools that we need to evaluate childhood anemia, now let's start with case-based discussion, in which I'll be discussing at least 10 different sorts of cases with different mechanism of anemia and different clinical scenarios, just to give you a snapshot of how childhood anemia is present in a very prototypical manner. And I would like to involve the residents in this because they're very simple cases. So the first case is a young child, is a 2-year-old boy who presented with OPD with illness noticed by the mother since last 6 months. And also the mother say the child is craving for soil and weird thing like oil plaster. Sometimes he just plucks and puts in his mouth. And the mother has also noticed that the child passes occasionally once in stool, and there is pruritus ani. On physical examination, you found the child to have moderate pallor. There was no icterus. There was koilonychia, which is nothing but concavity or the spoon-shaped appearance of the nails like this. Anthropometry showed there was moderate degree of wasting and stunting. Systemic examination was otherwise unremarkable. So quickly, can some resident volunteer to say what would be the most likely clinical diagnosis at this juncture? Anyone? Correct. It is very from this context, it is very apparent it is iron deficiency anemia. So now I'm giving you the hemogram parameters. So you can see there is severe anemia. Red cell count is pretty low. Reticulocyte response is poor. There is severe microcytosis and hypochromia. And red cell distribution width, which is around 14 to 15 normally, has been markedly increased, indicating what? Anisocytosis. Other parameters are preserved, but platelet count has risen. It's normally up to 4 lakhs, but it's risen up to 5.5 lakhs. And in the peripheral smear, you can see there are multiple microcytic hypochromic red cells along with target cells. So what do you mean by hypochromic cells? That when the central pallor of the red cells get widened, there is something what is called hypochromia, which indicate underhemoglobinization of the erythrocytes. And you can also see target cell. Target means what? We have all we have gone to several melas and have targeted these different things. So with charts, so very similar sort of thing. There will be a peripheral rim of hemoglobin, then again a rim of pallor, then again a second rim of hemoglobin followed by a central pallor. There is something what is giving you a target-like appearance. So both the target cell and this large central pallor indicate underhemoglobinization of the erythrocytes, which is very characteristic of iron deficiency anemia as well as in the thalassemia syndromes. But what really helps you to differentiate from a thalassemia from iron deficiency is that the red cell number is relatively always well preserved in thalassemics as compared to iron deficiency state, in which RBC number get tremendously decreased. Another soft pointer could be thrombocytosis. So thrombocytosis in iron deficiency anemia is pretty common to see. Often it goes beyond 10 lakhs, goes to platelet billionaires. And the reason behind that is a reactive process, because erythropoietin acts to some extent on the thrombopoietin receptors, also resulting in reactive thrombocytosis. So a clinical context along with the classical hemogram and the peripheral smear is enough to diagnose a case of iron deficiency anemia, and routinely performing iron study is not warranted. That message should be very clear, I think. So in this particular context, if we say what is the syndromic diagnosis, it is a hyperproliferative anemia because our retic was low, severe microcytic hypochromic anemia. And the diagnosis we have all told, it is iron deficiency anemia. So how do we do laboratory diagnosis? We have discussed about this. And again, I want to reiterate the fact that routinely performing iron study is unwarranted in a patient in which clinical context and the laboratory picture of hemogram and peripheral smear is consistent with iron deficiency anemia, you need not embark on doing iron profile unnecessarily. However, that should be also kept in mind that whenever you are treating a microcytic hypochromic anemia with empirical iron, and there have been response in the form of retic response and hemoglobin, that retrospectively also reassures you that yes, you are indeed dealing with iron deficiency anemia, right? So that again reduces your, the scope in which you should unnecessarily do iron study. That is not required really. So once you start treating with iron, typically the sense of well-being comes within first 24 hours. Reticulocyte response comes within 72 days, and by the week approximately it peaks, and the hematocrit starts rising by first week, and the rate of hemoglobin rise is typically 1% per day. That is around approximately what has been said, that 1 gram rise should happen at the end of 1 month. At least that response should have happened. Otherwise, it is called inadequate response. So that's a trajectory in which the clinical laboratory response comes once you have started treating with iron. So typically the management includes supplementation with iron, in which so these ferrous sulfate preparations have been used because they're very cost effective and biologically available. Bioavailability is very good for the ferrous form of iron. The dose is around 3 to 5 mg per kg per day. The frequency, OD dose can be given. People use BD or even TDS dose, and head-to-head randomized trials are available which have shown that OD dose is as good as giving BD or TDS dose. Problem can happen sometimes the child may not consume the whole volume because it is gastric irritant. So otherwise, efficacy-wise, OD dose can be as good as BD or TDS dose. So it is based on the clinician's discretion. You can decide on the frequency. Duration of treatment, we all know that hemoglobin has to normalize, but the story doesn't end there. You have to give for additional 3 months just to build the iron score in the marrow and the reticuloendothelial system. That's the treatment of iron deficiency. Right, sir. Right. Maybe in Indian context, sir, when particularly the dietary habit is very bad, there's a lot of vegetables which as phytate, oxalate may interfere with absorption of the iron. So bioavailability may be a concern. Intestinal parasitosis is a very common concern in the Indian population. So maybe in developing countries are relatively higher dose, maybe having a better bioavailability. I don't know if there is some study available to test it in a head-to-head manner. But any range between 3 to 5 should work nicely. So you should always remember to do deworming without going for any test for stool workup, etc. Just in a child with iron deficiency anemia, no harm giving a dose of albendazole to empirically treat deworming and to treat intestinal parasitosis. So let's come back to our index patient who had hemoglobin of 6.4, has started giving oral iron. The child came back after 3 months, but what was concerning in this case was that the child still has moderate amount of pallor. You did a hemogram, and the hemoglobin is still 6.8 gram per deciliter. They started with like 6.4 or something. It has hardly risen, right? The child has come after 3 months, and I have told that per month there should be at least 1 gram per deciliter increment. So it's really concerning to oral iron therapy. The child has not responded well. So what do you think? Can someone say 1 or 2 causes, and what are the possible reasons behind such a poor response to iron in such situation? What are the considerations that you should have in your mind? Anyone? Correct. Ongoing loss. Right. So, correct. So I think you people have told the most common causes. I'll be enumerating a few more uncommon causes also, but I think you people have told the exact commonest causes that should be thought in the back of mind whenever a child with iron deficiency anemia shows poor response to oral iron. So poor compliance. The poor compliance happens because it causes some metallic taste, some staining of the teeth, tongue. Patient develop constipation. Stools sometimes develop blackish discoloration. They're very minor side effect, but sometimes can be very bothersome for the parents that lead to poor compliance to iron. And often people give in a very improper way of administration, like along with milk or different vegetables, with the leafy vegetables and all, which can have very rich amount of oxalate and phytate, which can interfere with the absorption of the ferrous iron. Inadequate dosing. Despite iron deficiency being a very common problem, unfortunately, many healthcare professionals may somehow prescribe an inadequate dose. Then malabsorption, like sir has told, celiac disease, or even heavy intestinal parasitosis is probably the most common cause of malabsorption in our context. Ongoing chronic blood loss. Again, intestinal parasitosis like hookworm infestation can lead to chronic blood loss to the GI tract, or in an adolescent can be a undiagnosed menorrhagia, maybe is a common entity in which ongoing blood loss happens and may be undetected. So these are the different situations that you should always think. Cow milk protein allergy in young children. So all these things we should always keep in the back of our mind when approaching a child who had poor response to oral iron. And when you have excluded all this, then yes, indeed, you should question yourself: am I indeed dealing with an iron deficiency anemia, or it is or some alternate diagnosis that's something that needs to be entertained and needs to be ruled out? That should be kept in mind. But before that, all these common 1, 2, 3, 4, 5 causes needs to be excluded from your list before you need to embark on further investigation to work up for any alternate diagnosis. So what typically we do is confirm dose and compliance. And once you have done that, then you can do a serum iron study, because you have now ruled out cerebroblastic anemia, etc. You do a HPLC, because beta thalassemia syndromes need to be excluded at this juncture. You do a celiac serology, there is 1% prevalence is there in the country of celiac disease that needs to be ruled out in such situation. You should do a stool examination to screen for parasitic cyst, ova, and occult blood, urine hemosiderin, just to see if there is any occult hemoglobinuria happening, like in a context of PNH, etc. And when all this work you have done, you have kind of exhausted your list, then you have to do a bone marrow examination and work up for some genetic forms of iron refractory forms of iron deficiency anemia. But this is a last resort. Before that, all these common entities needs to be excluded one by one in a very systematic way. Right. So our child, I'm sorry, it has got hidden. So our child was tested for TTGA serology and was found to be positive. So he became very unhappy because now he has to be on gluten-free diet for lifelong. Okay. So at any point, if you feel any question, please feel free to interrupt me and ask the question. So I'm moving to the case 2. So the same patient, the previous patient, is iron deficiency anemia. So mother was very kind of curious, or was afraid that let's see how is my other child doing. So she overzealously gets a complete blood count done of her elder child without you requesting it. She just herself got it done. It's very common. My other child is younger child is anemic. Let's see what is the hemoglobin. My older child is 7 years old. The fellow is absolutely well otherwise. The child was then subsequently with the report, the mother came to you in your clinic, and you found the child is absolutely fine and has mild pallor. In the hemogram, hemoglobin is 9.6 grams per deciliter, which is like a mild anemia. Red cell number, red tick, LCDSC, platelet are all preserved, but there is indeed microcytosis and a bit of hypochromia. So the syndromic diagnosis, it is a very mild anemia, but if I have to classify, I will classify this as a hypoproliferative anemia because red tick is low and it is indeed microcytic hypochromic. Can someone offer some differential? Do you think it is absolutely normal? There is some abnormality. It is not absolutely normal. Hemoglobin 9.6 is indeed a mild anemia. So in this context, with this clinical picture and the hemogram, what is the most consistent or likely differential diagnosis can someone offer? Thalassemia trait. I'm so happy. Correct. So clinical possibilities in this context, particularly when you have a mild anemia, it preserved red cell number. That is something which always, and along with significant degree of microcytosis, despite having preservation of hemoglobin. I think that is the most characteristic feature of beta thal trait. That when you have mild anemia, but the amount of microcytosis and the amount of abnormalities in the peripheral blood smear are disproportionately marked as compared to the severity of anemia. That's what should point towards. It's a soft pointer towards the diagnosis of beta thalassemia trait, and plus red cell number often remains well preserved despite the child being anemic. So in this context, you have thought of beta thalassemia trait. What will be the next investigation that you will like to do? Hemoglobin HPLC. I'm sorry. Yes, so Menser index is a very popular screening test, but indeed it's not confirmatory. It can give you more confidence, but indeed to label a child a beta thal trait or not, which is further ramification indeed, you have to do an hemoglobin HPLC. But that is very correct. That yes, we can do an Menser index which has variable sensitivity and specificity, but indeed it can give you some soft pointer towards differentiating between iron deficiency versus thal trait. So Menser index is a ratio of mean corpuscular volume divided by red cell number. And as I told, that iron deficiency red cell number will be very low. Beta thalassemia trait red cell number will be preserved. So naturally, if the denominator is low, the ratio has to shoot up. Naturally, in iron deficiency anemia, often your Menser index are like 14, 15, 16 versus beta thalassemia trait Menser index is well below 13. So this table, I think from MBBS level, everyone is familiar about. I'm not dwelling on it. Just again reiterating the fact that when differentiating iron deficiency from thalassemia trait, this pointer on RBC number is something which really helps you to dissect these two out. And another common cause of microcytic hypochromic anemia in general pediatric practice is anemia of chronic disease. Now it is called anemia of inflammation. It can be any form of chronic disease like a kidney disease or rheumatological disease or any chronic infection, etc. And in that condition, Iron study is a thing only that helps you to differentiate. So in this particular context of anemia of chronic disease, the remarkable feature of iron profile is that everything is going to be low. Serum iron, TIBC, everything is going to be low except for serum ferritin, because ferritin is a marker of inflammation. So there is a signatory iron profile marker of anemia of inflammation. So back to our index patient. So as you people suggested, I did hemoglobin HPLC, and as you can see that HbA2 is well above the cutoff of 3.4 to diagnose beta thalassemia trait. So child was now labeled as beta thalassemia trait, and the parents and sibling were also requested to get an HbHPLC. This is something often the clinicians do forget. If a patient has been diagnosed with beta thalassemia trait, it is our responsibility to at least request the children and the sibling and the mother and the parents to get that screening done. Otherwise, when medical hazard can happen, you can understand, I guess. Okay. So now moving to my third. Sure, ma'am. Sure, ma'am. So all the ferrous preparation should have good bioavailability. Like most of the things which are available are like ferrous sulfate, ferrous ascorbate, and trials shows that ascorbate and the sulfate preparation have equal, very comparable bioavailability given the populations. So personally, I'm not advertising anything, but personally, so right. Right. Is it tonophenol? I don't know. I don't use it much. Right. What I prefer to use is Vitcofol. Ferrous ascorbate. Yeah. Right. Right. All the recipes should, yeah. Yes. Sure, I concur. What you call the innovative molecule or the starting molecule, it has sort of a bit of more adverse effect as compared to the others. Yeah. Not much of a difference, definitely. And tonophenol, the most important thing is you have to mention tonophenol pediatric syrup, which has got 80 mg per 5 ml. And tonophenol syrup per se has got 50 per 5 ml. So very important to prescribe what you want. Tonophenol drop is different, tonophenol pediatric is different. Yeah. Tonophenol syrup is different. Right. So whoever is prescribing whatever brand, stick to that. Whichever you are confident and comfortable with, stick to that so that you don't get the doses now. That's sure. Yes, that is important. Yeah, absolutely. Yeah. Whatever is possible, like tonophenol is much cheaper as compared. Even Vitcofol is cheap. Yeah. So that's one advantage. Sure. And like stick to one or two brands that you are comfortable with. It doesn't matter. Yeah. Most of the brands, the preparation is like elemental around 30 to 35 milligram per 5 ml is kind of for the residents I'm saying. For 5 ml, it will be around 30 to 33 milligram per 5 ml. So moving on to the third case. So this is a young baby, a 1-year-old girl child. The baby is still exclusively breastfed without any weaning being done. Presented to pediatric OPD. The concern is that the child is progressive pallor for last 1.5 months. And is also failing to gain developmental milestones, particularly in the motor developmental sector. On examination, the child has severe pallor, has acral hyperpigmentation, as is evident from this picture. In the upper limb, in the arms dorsum, you can see there is marked picture of hyperpigmentation. There is generalized hypotonia. Baby has Ans's look. Hair also look quite dry, lusterless, and hypopigmented. Any clinical possibility? Vitamin B12 deficiency, very correct. So it is. So again, it is you can understand it is nothing but the clinical pattern recognition. A young baby who has not been started on complementary feeding and is exclusively breastfed, has developmental delay, hypotonia, etc., acral hyperpigmentation, and anemia. The clinical context gives you a clue towards the diagnosis of megaloblastic anemia. So we have done a CBC with hemogram. There is severe anemia. There is leukopenia. There is thrombocytopenia up to moderate extent, and you can see there is remarkable degree of macrocytosis. In the peripheral smear, you can see there is red cell macrocytosis, and what is remarkable is hypersegmentation of the polymorphs. So that is very characteristic of megaloblastic anemia. So how one does evaluation in the laboratory? So in the hemogram, often you get isolated anemia, In the severe deficiency, you may end up getting bi or even pancytopenia because it suppresses hematopoiesis in a non-exercise specific manner. All the three lineages can get suppressed. There are macrovagocytosis and hypersegmentation of neutrophil. The classical book definition is that there should be at least 5% or more neutrophil should have hypersegmentation. There is more than 5 lobes. Some of the book says at least 1% should have more than 6 lobes. So whatever this book definition may be, demonstration of hypersegmented neutrophil is something very classical of megaloblastic anemia. Biochemical assays are now increasingly being used, serum or RBC folate being indeed a better marker between B12 level, but more than B12 level, different biochemical assay of vitamin B12 function, like your serum and the urine methyl malonic acid and serum total homocysteine are better marker of vitamin B12 metabolism than other. But again, I want to reiterate, in a typical clinical context, when you have a classical red cell indices of macrocytosis and peripheral smear showing hypersegmented neutrophil, again, there is probably no need to embark on routinely doing this biochemical assay. So I will not dwell on this management issues much. I think everyone is familiar about it. So coming to the fourth case, it is again a young baby, a 9-month-old infant boy, presented to the emergency department with complaint of poor feeding, lethargy, and fast breathing for just last 2 days. And when you probed, the mother also told that yes, she has noticed the baby getting progressively ill for last 1 to 1.5 months. On examination, the baby had severe pallor, mild icterus, tachycardia with gallop rhythm. The child is in CCS, has splenomegaly, which is quite big, around 5 centimeters under the costal margin. So the syndromic diagnosis here is a severe anemia with organomegaly in infancy. So can someone volunteer to just offer me 2 or 3 differentials in this context? Just mentioning thalassemia is not sufficient. What thalassemia? Yeah. Yes. Thalassemia major probably. Anything else? Any other differential? A baby with severe. Sorry. Any other hemolytic anemia? But that is little vague now. You can say a severe form of inherited hemolytic anemia. Okay. Any other differential? Apart from hemolysis, can it be anything else? Okay. So in such situation, the most common differential that we entertain are the thalassemia, other severe forms of hemolytic anemia, like a severe form of HS, etc. But typically they don't present in the infancy. But obviously, you have to keep in mind other conditions like storage disorder, infantile leukemia, tortoise group of intrauterine infection should also be taken into consideration. So we did a hemogram with peripheral smear in this patient. There is severe anemia. There is marked leukocytosis, 76,000, with differential pattern being more or less fine. Platelet count is preserved. There is severe microcytic hypochromic picture, and RDW is again increased, indicating anisocytosis. Peripheral smear was done, microcytic anemia, no atypical cells. Biochemical profile was showing unconjugated hyperbilirubinemia. So the resident who was managing in the emergency department as a knee-jerk reflex thought it to be acute leukemia because having this marked leukocytosis in a baby with anemia and organomegaly, nothing wrong in that. So was started on allopurinol, hydration, and the TLS prophylaxis. And 1 unit of PRBC transfusion was given in the night. So what next? Anyone? Quickly. Okay. So before thinking much about the subsequent evaluation, let's see what are the differentials and how one should dissect it out. So as we have said that the differentials could be 3 or 4 I have offered. So if there is accompanying bleeding manifestation in a baby with anemia and having organomegaly, there is accompanying bleeding manifestation, you should think about other differentials like infant leukemia, storage disorder, etc., rather than thinking in the line of a hemolytic anemia. If there is accompanying developmental delay, microcephaly, growth failure, and all, you should think in the line of storage disorder, torch infections. If there is jaundice, indeed, you should think about hemolytic anemia. And if there is a sudden drop of hemoglobin, it was absolutely well 2-3 days back, and if there's a sudden drop in hemoglobin, or if there's accompanying hemoglobinuria, you should think about autoimmune hemolytic anemia. That also can be seen occasionally in young babies and infants. So I'm coming back to our index child. So our child had mild jaundice. There was no other cell involvement, platelet count, etc. were fine. Microcytic hypochromic anemia was there. There was marked anisopoikilocytosis and high circulating nucleated RBCs. So that points towards the diagnosis of thalassemia syndrome. So that was confirmed with a hemoglobin HPLC. So, but for this baby, HPLC cannot be performed because in the night, child was given a transfusion. If you do HPLC, what will happen? It just represent the transfused RBC. So this information is very vital. It is very simple science, but often you do this mistake. Post-transfusion, at least you should wait for a period of 3 months for those transfused RBCs to get clear from the circulation. Otherwise, it will not be truly representative of the patient's own hemoglobin. But you can really bypass this problem by simply doing HPLC of the parents. Because thalassemia, as we know, is autosomally recessive disorder. If the child is thalassemic, indeed the parents have to be trained. So as you are considering thalassemia syndrome in this given child, no one obstructs you from doing a hemoglobin HPLC of the parents. So we did that, and what it is showing? Both the parents are HPLC showing it is that both the parents are beta thalassemia trait, which is often called beta thalassemia minor, often called beta thalassemia carrier. All these things are same. Beta thalassemia trait is equals to beta thalassemia minor is equals to beta thalassemia carrier, right? So both the thalassemia syndrome in the baby. Got the point? Clear? Okay. Oh, right. Yeah. Sorry, I forgot. That is very interesting. That is because of nucleated RBCs. So the automated Coulter counters, they are often not that brilliant enough that they can discriminate between a nucleated RBC versus WBC. So they can falsely count nucleated RBCs as WBC, which can give you a spuriously high WBC. So I've given the situation not as a hypothetical. Indeed, it is actually very common. During my residency in PGI, I have seen several times it will happen. The junior resident in the emergency in the night, despite the child being anemic, will push a lot of fluid, thinking the child will be having leukemia with high counts. And a simple peripheral smear can really discriminate it very easily. So that is the reason the WBC count was high, because NRBCs were miscounted. All right. So coming to my next case, this is a relatively older child, a 7-year-old girl child, who is having history of fluctuating jaundice. That is the only complaint. Fluctuating jaundice for last 2 years of age. And at 5 years of age, child had once drop of hemoglobin of 6. That time the baby had a pneumonia. Was admitted in a hospital, hemoglobin was found to be low. And that time a child received a transfusion. So this time when you were examining, when she is 7 years old, the child is moderate pallor and has jaundice. He has hemolytic phases, which is a form of zygomatic prominence. And you did anthropometry, which was showing growth failure. Liver, spleen were both palpable around 3-4 centimeters below the costal margin. Any differential? I'm sorry? Any differential? Why? Right. So I think given information, what we can all tell is probably a chronic hemolytic anemia. But the information which is very striking here, this is hemolytic phases. We know so many chronic hemolytic anemias, but a handful of them only can lead to hemolytic facial changes. This is because more than hemolysis, it is an ineffective erythropoiesis that leads to remarkable marrow expansion that leads to this kind of typical thalassemic phases, or the so-called hemolytic phases or chipmunk phases. So chipmunk phases is a very strong surrogate marker of ineffective erythropoiesis more than hemolysis. So autoimmune hemolytic anemia, G6-PD deficiency, hereditary spherocytosis, and other common hemolytic anemias, they hardly ever to none ever lead to hemolytic phases. Hemolytic phases is a marker of ineffective erythropoiesis, and apart from thalassemia and a very rare some condition like congenital dyserythropoietic anemia, hardly, and sometimes in very severe ages, we hardly ever encounter hemolytic phases in any other hemolytic disorder, right? So whenever in a child with jaundice, anemia, organomegaly, you get hemolytic phases, you should think it is not only hemolysis. More than that, a large bulk of ineffective erythropoiesis is also underplaying the situation, right? So that message should be clear. So we did a hemogram which revealed microcytic hypochromic anemia, platelet count, etc. were fine. Reticulocyte count was 2.3%, which is low only for this given degree of anemia. There were target cells and anisopoikilocytosis. What is the syndromic diagnosis? It is a chronic extravascular hemolysis, right? Agree with that? Chronic extravascular hemolysis. But apart from that, what is very prominent here is the ineffective erythropoiesis. If we just say it is an extravascular hemolysis, it will be very bland. It is not so bland. It says on top of that, a cherry. Cherry is what? Ineffective erythropoiesis. How do you know that? Because child has very prominent chipmunk phases. Right. So what are the common causes of chronic extravascular hemolysis? We know several from our book, but if you go to any standard pediatric hematology clinic, the top 2 conditions of chronic extravascular hemolysis that we deal on everyday practice are hereditary spherocytosis and thalassemias, right? Now, why I've written all this complicated term, non-transfusion dependent thalassemia and all? It is because the thalassemia major, so these major and intermediate terms are all obsolete. We are still using by error. Simply by error, we are still using. So you should refrain ourselves by using this old terminologies like thal major, thal intermedia. Nothing like that exists. Modern terminology is transfusion dependent thalassemia for thalassemia major and non-transfusion dependent thalassemia or NTDT for thalassemia, which is different from using all these older terms like major and intermediate. So in thalassemia major, the common belief is that hemolysis component is very less. The all cause of anemia is ineffective erythropoiesis. Whereas in the context of thalassemia intermedia or so-called non-transfusion thalassemia, there is a big bulk of hemolysis along with parallelly going ineffective erythropoiesis, right? So these are the common two conditions. So after you have discussed all this, can someone tell me what was the differential in that case? That case with chipmunk faces and all, this fellow. Yeah, it's non-transfusion dependent thalassemia, right? Because what I have told that hereditary spherocytosis and etc., they will hardly ever lead to chipmunk faces, right? So these are the typical clinical features of these situations. So NTDT will present with thalassemic faces and anemia of variable severity. So just to give you this idea that there is something called non-transfusion dependent thalassemia. They are indeed thalassemic. They are homozygous thalassemic. Only difference from thalassemia major is that they are not requiring lifelong transfusion. I have brought this case just to re-emphasize this fact. They are nothing but they are not thalassemia minor. This confusion is very common among the residents. Many are. They are not heterozygous or trait. Traits are asymptomatic. Amitabh Bachchan has a thalassemia trait, right? So they're normal. Traits are normal. Intermedia is what? They're indeed homozygous with thalassemia, carrying two mutations in the beta globin gene. Only difference is that their severity is less as compared to thal major. They can have all the complications like thalassemia major. Only difference is that they're not requiring monthly transfusion lifelong to sustain their life. They can require transfusion intermittently or occasionally during stress, infection, trauma, surgery, this, that, pregnancy, and all. Otherwise, they're not requiring routine transfusion. No, not more, maybe equal contribution. Thalassemia major, hemolytic component is very less. It's predominantly ineffective erythropoiesis will lead to anemia in thal major. In what? Right. So in thalassemia major, no, what happens? They are regularly transfused. They are regular because otherwise they can't survive. So once you are regularly transfusing, you are basically suppressing their ineffective erythropoiesis. If you don't transfuse, what will happen? That marrow will try to expand and produce, but will not be able to do because of underlying hemoglobinopathy. So that's why you are very correct. The question is very, I think, very thoughtful question, right? But chipmunk faces happens somehow more in the patients with NTDT than thal major, particularly the thal major who are poorly transfused, like getting transfused occasionally, 6 week, 8 week, 12 weekly. They do develop. Otherwise, NTDTs often do develop chipmunk faces, right? Fine. So, so back to our index case, we have done a HPLC of the parents as well as of the kid. And for this patient, we can see that the HbA was 72%, HbA was 25%, and both the parents were trait, indicating a diagnosis of thalassemia syndrome in this patient. So I'm repeatedly using, if you notice, this term called thalassemia syndrome, because the differentiation between thalassemia major and intermedia is not based on any HPLC or anything. It's totally based on the clinical trajectory, how one is behaving. Is the patient requiring regular transfusion to survive or is not? So based on the clinical profile, you discriminate. There is no HPLC or no lab test to differentiate between thal major or thal intermedia. It's completely a clinical judgment-based discrimination. That point should be very clear. So our index patient that thalassemia intermedia or so-called NTDT now, they can have anemia of variable severity. And this is the picture, I think, very widely used picture, shows that how the spectrum of non-transfusion dependent thalassemia can be. This can be very mild, but they can, and the other extreme can be, they can be requiring very frequent transfusion. So NTDT is a very complex entity. You may not be knowing in detail in MD level, but just to know that something like that exists. Okay, coming to the next case, it is a 7 years. Sure. Oh, sure. No, that's all right. So let me then choose cases. I'll choose another case. So it's a 4 years old girl child presented to emergency department with acute onset passage of polar colored urine like this. Had a history of URTI 1 week back. On examination, severe pallor, mild icterus, tachycardia, gallop, and mild splenomegaly. You requested blood bank to give blood. Blood bank says that they're having a lot of problem in cross matching. Any guess? Autoimmune hemolytic anemia. So this is very characteristic. Whenever you get hemoglobinuria, the differential that typically comes in our mind includes C6 deficiency, one of the commonest, autoimmune hemolytic anemia, hemotoxic snake envenomation, not to be forgotten about, and then the other rare causes come. But there are different common causes of acute IV hemolysis. And when blood bank wants you to say that there is cross match difficulty, life is very simple for you. The diagnosis is nothing but autoimmune hemolytic anemia. So that information I wanted to give. This I will skip. This is another interesting case. 9 years old girl, anemia requiring transfusion for last 4 months. 7 transfusion the baby has required till so far. History of intermittent gum bleeding also. On examination, severe pallor, multiple petechia, and has bilateral thumb abnormalities, right? Also has short stature, multiple capillary macules. Any guess? Fanconi anemia. So what was the pointer? Multiple phenotypic abnormalities, capillary macules, thumb abnormality, short stature, etc. Right? So in a patient who has pancytopenia-like presentation without having organomegaly, you should actively look for all these phenotypic abnormalities. And the last case, 12 years old boy, severe anemia, fever for 2 weeks, intermittent epistaxis, generalized body ache, examination, pallor, petechiae, hepatosplenomegaly. Any clinical differential? Sternal tenderness, correct. Acute leukemia, right? Yeah, you did a CBC which showed there is blood discharge, yes, high TLC, low platelet count, and there is circulating blast. So why did I pick up this situation? Because just to reiterate the fact that in an anemic child, you should also look into whether there is any evidence of other cell line involvement clinically. If it is so, then you should widen your differential diagnosis in that way. Right. So I think these are very, so this is very useful that whenever you are approaching a child with anemia, you just see if it is anemia standalone or there is any accompanying other cytopenia, particularly there is clinical evidence of thrombocytopenia in the forms of skin and mucosal bleeding. If you're dealing with standalone anemia, now see what is the retic. If you're dealing with low retic, it's a production problem like nutritional anemia, thalassemia, anemia of chronic disease, etc. If the retic is high, you're dealing with hemolytic anemia. Once you have reached up to this point, you are welcome to do workup for hemolytic anemia. Before that, at this point, you should not do workup for extensive workup for hemolytic anemia. I just want to reiterate that you should do in a very stepwise, rational way. If there is bi or pancytopenia and not anemia standalone, you see whether there is organomegaly or not. If there is organomegaly, you're dealing with something like leukemia or maybe an autoimmune pathology. If there is no organomegaly, it is an intrinsic marrow failure, which can be an aquadysplastic anemia or a syndromic form like a dysplastic anemia, dyskeratosis congenita, etc. These, I think, from the Robbins textbook, we all know. I'm not dwelling. So I come to my last slide. So childhood anemias are a pretty common pediatric health issue with a very sizable global, country-wise, as well as West Bengal state-wise burden. Anemia is not a disease per se, but you should always provoke the physician to find a root cause for that. And workup should be in a very systematic way. Identification of a syndromic pattern by gathering all the clinical as well as the laboratory parameters from the hemogram helps in narrowing down your differential, and careful interpretation of the complete blood count, peripheral blood film, retic, red cell indices. If you do at least this, that in themselves helps you to solve the mystery of anemia in a large bulk of patients without taking help of very costly and labor-intensive investigation. That message I wanted to give. Thank you for your kind attention.